Good afternoon, everyone. I am Dr. Shikha Verma, Medical Advisor for Lupin Oncology. Lupin is an innovation-led transnational pharmaceutical company and is one among top 5 Indian pharma companies. And we pride in belonging to an industry which makes a difference in lives of the people. On behalf of Lupin, I welcome you all for today's webinar. The topic of webinar is cancer care during COVID-19 pandemic, and the speaker for the session is Dr. Sumant Gupta. Dr. Sumant is HOD and Senior Consultant at Sarvodaya Cancer Institute, Faridabad. He has done his TM in Medical Oncology from prestigious Cancer Institute in Chennai and has special interest in solid tumors, hematological malignancies, and bone marrow transplant. Sir has been a winner of TYSA Young Scholar Award for the Best TM Oncology Fellow in 2015 and has received multiple awards at different occasions. He has more than 10 national and international publications to his credit and is currently the Executive Committee member of Indian Society of Oncology and Breast Cancer Foundation India, and also a founder of Executive Secretary of National Cancer Society. We welcome you, Doctor. Over to you.
Good afternoon, everyone. Welcome to the webinar, and I'm thankful for Lupin Oncology for hosting this. I really apologize for the delay. It was because of the patients, and I think patient care is the primary thing. COVID-19, the pandemic, has changed a lot of things for all of us, and I think it will change a lot more things for all of us during this time. So cancer care has changed a lot, and cancer care is one of the only treatment continuum which is going on during this time. Can we have a change of slide, please? Slides. Yeah, next slide, please, Mr. Rahul. So the coronavirus prevalence has crossed 6 lakhs and India has become the third largest country in the world in the corona pandemic. Next slide. According to WHO, the virus belongs to the coronavirus family, which is the adenovirus. It is a novel strain discovered in 2019, transmitted between both animal and the people with an incubation period of 2 to 14 days after the exposure. So this is one of the first viruses which have such a long exposure incubation time. And this is the reason why the symptoms can be very, very heterogeneous in all the group of people. Human to human transmission rates are very, very high, and there is no known treatment or immunization yet for this particular virus, which is called as corona or COVID-19. Next slide, please. So how do the people get infected? It can be through the animals, through bats, which was supposed to be the first vector. But the most common problem nowadays, which we are having, is the human-to-human transmission. That is why the concept of social distancing, the concept of masking, and the concept of hand sanitization, which has been the three things, has come. There have been multiple strains of these viruses which has come into the picture, and because of this high transmission rates of this virus, there has been various families of these coronaviruses like the beta coronaviruses, the gamma coronaviruses, and the delta coronaviruses, which have been found out, and these transmission rates have been a major problem. World over, around 20 million cases have been there. India alone has around 6 lakh coronavirus cases active as of today. Next slide, please. Can I have the next slide, please? Individuals with cancer are more susceptible to infections. The individual with our disease have to have an increased risk of COVID-19 and have a poorer prognosis. The outcomes are poorer with cancer patients. Timely screening is important. The need to prevent the spread of coronavirus to our patients is very important in the medical system. Routine visits to healthcare facilities are safe, and regular screening tests should be rescheduled after the restriction to slow the spread of this disease to the cancer patients. So, coming to a simpler term, coronavirus has become a way of life or a new normal for us. So, our cancer patients need to be protected from this disease, and they need to be treated in the same manner as they were being treated, but they have to be treated in a COVID-free environment. Next slide, please. Various trials and various studies have been done. Some of these show that 1% of the total COVID-19 patients in the Chinese study had shown that they had a history of cancer. The three major strategies were proposed for the cancer patient. One, an international postponing of the adjuvant chemotherapies, stronger personal protection, and more intensive surveillance. So initially, we were proposing that the cancer patients should be kept inside. Their treatment strategies should be postponed, whether newer drugs like the targeted therapies or the immunotherapies should be postponed. But now the newer data in all the major guidelines, whether the ESMO guideline or the ASCO guidelines, are coming to a newer term where we are saying that all the major therapies should be continued. Even the immunotherapies, except for rituximab, is safe to the COVID patients, but a proper screening should be done, and all the chemotherapy should be done in a clean, isolated environment where the COVID patients are safe and they are given a COVID-free environment. Next slide, please. So what can we do? The aim should be to reduce the exposure to the COVID virus, not to lose control over the cancer. That is, the efficacy of the anti-cancer treatment should be controlled, and reduce the workload or the exposure of our manpower. That is, the cancer treatment team should not be exposed to the COVID. Next slide, please. If we come to the cancer fatality rate, there was a comparison in this study also. There it was compared that overall the cancer fatality rate was quite high, that the cancer patients had a fatality rate of 3.8. Patients with no comorbid conditions, it was 1.4. In patients with cancer plus cardiovascular, it was 13.2. With diabetes, 9.2. With hypertension alone, 8.4. And with, say, chronic respiratory disease, it was 8%. Next slide. Guidance from ASCO on the cancer care during the pandemic. Elective surgeries at inpatient facilities had to be rescheduled if possible. By elective surgeries, the definition is changing day by day. Elective surgeries nowadays does not mean that the cancer surgeries. By elective surgeries, we have a meaning of like chemoport removals or surgeries which are adjuvant surgeries like FJ removals, chemoport removals, or surgeries which do not change the stage of the patients or which are not essential for the stopping of the cancer per se. Systemic treatments like chemotherapy, systemic treatments like chemotherapy, immunotherapy, leave the patient to vulnerable to the virus, but it is not uh, a guideline to stop these therapies. So stopping anti-cancer immunosuppressive therapy is not recommended, as there is no direct evidence to support the change to the regime of the patient. So the basic regime of the patient should not be changed. For patients already in deep remissions, like patients of multiple myeloma in deep remissions, in these cases, the maintenance therapies can be changed. Or patients on breast cancer, patients who have been cured, those who are on 6 monthly zoledronic acid treatment, these patients can be deferred for some time. Next, please. If the other concept which has come in is we have to see the local habitat of our patient. If we are in a zone where the coronavirus cases are too high, in these cases, in these scenarios, we have to alter the treatment as per our local needs, whether home-based chemotherapies can be offered, whether we can switch some therapies to IV to oral. But all these have to be kept in mind where the patient's total cure rates do not change and where any need of prophylactic antiviral therapies can be done, or whether we can decrease the rate of steroids or anything which can decrease the immunity of the patient further. Next, please. Next slide. Can I have the next slide, please? So basically, all these guidelines, initially when they came in February and March, there were a lot of apprehension whether the drugs have to be continued, whether the IV chemotherapy should be stopped. But as and when we are living with this guide, whether when we are living with these COVID situations, we are understanding that we cannot change the treatment of the patient because cancer per se is more deadly than the COVID. The cancer has a more killer rate than the COVID per se. In India, COVID has only a rate of 2 to 3% of fatality, where cancer is a more deadly disease. So we cannot change the cancer treatment immediately. So all the cancer treatment should be continued. But where the patients are in deep remissions, or where the patients only have to get treatment for prophylactic treatments, in those scenarios, we can always defer those treatments or increase the duration of these treatments. So the clinical decisions are to be made by the clinical teams. So as these slides show, there is no direct evidence that changing or withholding chemotherapy with immunotherapy will change the COVID rates. Clinical decisions should be individualized and they will be made by the clinical team which are dealing with the patient, and it all depends on the patient's tolerance. But again, the most important part of the treatment decisions are that there should be social distancing in the clinics, the patient should come with proper appointments, and the hygiene of the patient and the hygiene of the clinic where the chemotherapy is being given should be properly maintained. Anecdotal and controversial information suggests that RAS antagonists have shown increase in acquiring COVID-19 and reduce the severity of the disease in those infected cases. But these are all anecdotal and we do not have exact evidence. Clinicians and patients will need to make individual determinants based on the potential harms of delaying the cancer treatment and cancer surgery. So we need to sit with our patients, them the pros and cons of delaying the treatment, and then only they will understand that what is most important, whether the cancer treatment can be deferred with the safety or whether the treatment needs to be given on time. Next, please. Again, if we come to the surgical part, it is again the need of the art to sit with our patients, tell them the risk benefit involved, and in the situations where neoadjuvant therapy has very small benefits, whether in these conditions, whether we can go the neoadjuvant chemotherapy approach and directly go for surgeries to decrease the duration of the therapy and decrease the duration of hospital exposures to our patients and finish the cancer treatment as soon as we can. Next, please. This is a clinical care triage framework which has been seen. So most of it shows the same what we have discussed, how and when the patient should be admitted and what has to be done. So most of these guidelines again show that much of it has been unchanged. Thank you. Next one. Again, the most important thing which COVID has taught us is that communication within the framework is most important. Communication with our patient, communication within our team, communication with the community is the most important key in the COVID era. Next one, please. So this is the approach to a critically ill patient or a suspected COVID patient. This is a guidelines published in April 8th. I will not like to go in detail because this is the ICU guideline and this will change with hospital to hospital. Next one, please. So ESMO has very clearly said, ensure the continuum of care, get prepared for the new normal, protect yourself and your team and the patients, and reinforce the support to the patient. So let us mask ourselves, let us maintain hand hygiene, let us maintain social distancing, and let us treat our patients with lot of care, empathy, and love. Next one, please. This is again the ESMO guidelines, which again says that reduce the number of visits, switch to subcutaneous oral therapies if possible, but again, do not change the patient outcomes, adequate training of the staff with PPE kits, and basic protective measures to be continued. Next one. Web-based teleconsultations. Yes, every one of us are doing, and this will be the new normal. Next one. So this is again a priority level. That's what I have been discussing, that patients cure rates should not be changed. Patients who are in the curative setting should not be hampered. So we should not think about changing from IV to oral or de-escalating therapies. We have to again understand that the rate of cancer cure should not be changed. Next one, please. So again, all patients have to triaged, all patients hospital visits should be minimized, cases should be prioritized on basis of their cure rates. No surgery no surgery should be deferred. Those with benign disease or those who do not need surgeries immediately can be deferred only. Next one. Same thing. MDTs, tumor board, should be done remotely. Let us not have lot of gatherings. Like we are doing a meeting where we are doing it from the hospital. Still, no one is gathering in single rooms. We are doing MDTs also through Skype and all channels like this. So let us minimize gatherings. Let us not have huge congregation of people so that we do not get infected and not all of us are hit together. Next one, please. These are the ASTRO guidelines for the radiation oncologists. Let us skip these. Can we have the next one? This is the radiation oncology guidelines. Next one, please. EBMT guidelines, the BMT guidelines have been very clear right now. We are only doing transplants for acute leukemias or where it is absolutely necessary. Transplants for myeloma and other disorders which have limited benefits or which can be postponed with maintenance therapies have right now been withheld. We are waiting if we get a vaccine very soon. So we'll be deferring those transplants till that time. So stem cells freezing and other procedures are right now on hold. Next one, please. Again, issues with allo transplant. Right now, in one of the major hospitals, we had this issue. The donor had a COVID positivity. So right now, allo transplants only with cryopreservations are being done. And most of the allo transplants are only being done for acute leukes. Next one, please. These are the ICMR guidelines for testing. It has been changed from day to day. I think today Delhi had a new guideline. In Delhi, they are saying rapid testing for all patients for chemotherapy. Next one, please. This is of April, so it is all. So this is the US FDA guideline. This is also has changed by today. So if we come to our Delhi new India guidelines, so most of them are the same: masking, hand hygiene, and testing all patients for cancer. Next one, please. Clinical trials again are suspended right now. Only very few clinical trials. I think only 6 clinical trials right now are recruiting in India. So most of the clinical trials are either extended or postponed. Next one, please. This is the ICMR guideline for the trials. Next one. So in conclusion, COVID pandemic has swamped the healthcare system. Right now, high CFR in cancer patients, judicious postponement of treatment has to be on the clinical oncology team. Change to oral subcute wherever feasible, but not to change the outcome of the patient. Emotional well-being, lot of talking has to be done, lot of care has to be given, and the treatment decision on the pandemic and the patient has to be a very precautionary principle. It has to be transparent, evidence-based, and the outcome of the patient should not change. Next slide, please. Thank you. Any questions are welcome, but again, the request to the Lupin team will be, please stay put at home. We'll be available on phone. You guys take care of your families.
Thank you so much, sir. Thanks for a very insightful session. There are like two questions. First question is in immunocompromised patients like cancer patients. Is it fair to rely on classical COVID-19 symptoms to administer chemotherapy?
No, ma'am. Today, Delhi guidelines have clearly come that for all patients for chemotherapy, from today we are doing rapid testing for chemotherapy. So, government of NCT has clearly said that all patients for chemotherapy have to get a COVID-19 testing from today. So, it is a very welcome change by our government.
Okay, sir. Sir, and like, is there any treatment modification in lung cancer patients during this COVID pandemic? Or
ma'am, for stage 4 patients, we are now offering a lot of oral therapies, where especially for small cell lung and others, where we know that the outcomes are very poor. But otherwise, even immunotherapy has come back. There has been a clear trial by the ASCO where they are saying that even the MABs are totally safe. Immunotherapy is totally safe. There is no increased risk. The only drug which has shown an increased risk is rituximab, where they are saying to defer rituximab as much as possible.
okay, okay.
I know your drug.
That's okay, sir. Patient is the priority, so that's
Yes.
okay. Okay, thank you so much, sir. Thank you so much for your time
Okay,
and
thank
have
you.
a great time ahead. Thank you, sir.
Thank you.